Hello, I'm Camila Gonzalez from the Technical University of Darmstadt, and I will present our work on detecting when pre-trained nnU-Net models fail silently for COVID-19 lung lesion segmentation. This is joint work with my colleagues from the TU Darmstadt and the Frankfurt University Hospital. Since the beginning of the COVID-19 pandemic, deep learning solutions quickly emerged for the detection and segmentation of COVID-19 related findings. However, systematic studies show that most proposed solutions are unreliable and have unclear clinical utility. One reason for this is the lack of external validation, which quantifies how well the model generalizes to new domains, such as data from different hospitals or populations. To our knowledge, no deep learning solution is used today in clinical practice, which outlines a clear loss opportunity of leveraging AI to ease the burden of clinicians during the pandemic. So why is external validation necessary? We see here the performance of an nnU-Net architecture trained with data from the COVID-19 lung lesion segmentation challenge. The data is heterogeneous in terms of acquisition protocol and patient demographics, and most winning solutions in the challenge use an nnU-Net. The expectation would be that such a model should generalize well. However, when we test this model on 3 other datasets, we see that the performance deteriorates significantly from that achieved on the in-distribution test data. So how can we still leverage such a model? Well, if we were able to detect samples very different from those in during training, for which the model is unreliable, we could still use some model predictions. Most models are not trained with auto-distribution detection in mind, so ideally, we should extract such information without needing to change the model architecture or perform extra training. The easiest way to do this is, of course, by observing model outputs, but it's a well-known fact that deep learning models fail silently, showing a high confidence for bad predictions. You may think that while detecting bad predictions is important for classification or detection, this is not the case for image segmentation, as bad segmentation masks should be immediately recognizable. This is the case for certain anatomical structures, such as prostate and hippocampus, shown here, which consist of one or few connected components and are easy to localize. However, it is not the case for glandulous opacities and consolidations caused by COVID-19. COVID-19 related lesions can occur in various forms, from covering multiple small regions to diffuse affection of the entire lung. This makes the task of quickly monitoring the segmentation masks time-consuming even for trained radiologists. Most out-of-distribution detection and uncertainty estimation methods take on a probabilistic perspective, often quantifying how much network outputs vary for different conditions, such as different network initializations or different input perturbations. We instead propose a simple approach that consists of observing the distance between latent spans features for train and test samples. The intuition is that the model is very unlikely to produce good predictions for features far from any seen during training. This is an inexpensive way to get epistemic uncertainty that can be calculated post hoc on previously trained models. So how exactly does our proposed method work? On the lower right, we see an image showing a regular segmentation pipeline, in this case exemplified with a patch-based nnU-Net. Below, we see how our method connects with it. We start by estimating a multivariate Gaussian for features in the training data. For that, we repeat the following process for each patch. We extract latent space features from the encoder and project this representation into a lower subspace by average pooling in order to reduce the dimensionality. We store this low-dimensional representation for all training patches and calculate the mean and covariance. For a new image, we start by creating an empty tensor with the dimensionality of the image. Then, for each patch, we repeat the previous steps. For the low-dimensional representation, we calculate the Mahalanobis distance to the training distribution and obtain a point estimate for that patch. The value is replicated to the corresponding patch size, and following the example of the patch-based nnU-Net, a filtering operation is applied to weight center voxels more heavily. By repeating this operation with all patches, we build an uncertainty mask. Finally, we can take the mean of all voxels to get a subcheck level metric. So how reliable is this method? We start by examining the performance of Monte Carlo dropout, which is an uncertainty estimation method that works on a post-hoc basis. The black circles in the plot are the in-distribution test samples, and the gray squares are out-of-distribution samples. The gray vertical line is the 95% true positive rate boundary, selected with validation data. The y-axis shows dice, and the x-axis the uncertainty. The green quadrant at the upper left corner shows the best possible scenario where we have good predictions and low uncertainties. The blue lower right quadrant shows cases that are badly segmented but detected as such with a high uncertainty. Clinically relevant is the lower left red quadrant, where silent failures are located. Monte Carlo dropout fails to identify several out-of-distribution samples, which are bad predictions. In comparison, our method detects all cases of silent failures for out-of-distribution data. The only out-of-distribution samples that are assigned low uncertainty scores are samples for which good segmentations are produced. Here's a more thorough comparison with other post-hoc uncertainty estimation methods. The proposed distance-based method achieves the lowest false positive rate and detection and calibration errors, and the average dice of samples on the left side of the boundary to the right is consistent with the in-distribution dice. However, the segmentation calibration error is still high at 0.125. We see this limitation in the plot in the yellow quadrant, where several well-segmented cases are assigned high uncertainties. This means that we can safely use the model for some cases, but model utilization is not optimal. I would like to now briefly show some examples. We see here a very good prediction with a dice of 0.875. All compared methods assign this case a low uncertainty. Below, we see a very bad segmentation, where multiple regions are misidentified as being infected. However, this is not immediately obvious for the untrained observer, as ground-glass opacities can manifest in multiple lobes simultaneously. Here, our model is the only that identifies this case as a bad prediction with an uncertainty of 0.616. To conclude, the failure to leverage automatic image analysis during the COVID-19 pandemic was a lost opportunity. However, the pandemic demonstrated the value of time-saving workflow enhancements. The problem was partially because even state-of-the-art models trained with large heterogeneous datasets are susceptible to distribution shift. When this occurs, models fail silently, and because infectious lung tissue in chest CTs varies greatly in terms of shape and location, bad segmentations are not immediately detected. In practice, the best performing models are used, and auto-distribution detection is a secondary goal, so our methods should work post-hoc and integrate into existing pipelines. However, by reliably identifying silent failures, trained models can be utilized safely. Thank you very much for tuning in on my presentation.